Hello, everyone. I'm going to give a short 30 to 40-minute lecture on advanced resuscitation techniques. Now, this is it's a sort of high quality CPR together with a few other elements, which I will elaborate on within the course of the lecture. So I'm just going to start and I'm going to share my screen. Hang on a second. Okay, so basically, ART stands for Advanced Resuscitation Techniques. And at its core, it's actually a novel resuscitation technique which involves high performance CPR. And the ultimate goal, of course, is to improve outcomes, which include improved ROSC rates, improved hospital survival to hospital discharge, as well as good neurological outcomes for patients that are discharged. And this uses advanced techniques and new technology, all right? So all in all, it's a paradigm shift in the way we approach cardiac arrest, as well as a sort of a paradigm shift in the way we teach ACLS as well. So this model is not new to most of us. As you can see, the goal of resuscitation ultimately would be to have someone survive, walk out of hospital with a good neurological outcome. And a good neurological outcome is defined as a CPC score of 1 to 2 in most research papers. So I suppose the question then comes as to what is wrong with our current resuscitation model. Every 2 to 3 years, we go through BCLS and ACLS. Now, while this is important for people who do not resuscitate frequently, for those of us that are heavily involved in resuscitation and do it on a routine basis, I'm sure many would agree that ACLS and BCLS are fairly rigid and inflexible. It prescribes one way or a template to resuscitate patients. However, it doesn't individualize care, and it promotes a standardized model of care for all patients as well as all care providers. So while this is important and it's not something that we're going to do away with when it comes to training the masses, when we talk about training resuscitationists, we want a more directed and a more individualized and personalized approach, okay? So ACLS and BCLS, while it's been put in practice for a long time, outcomes haven't changed drastically. And where outcomes have changed, it's not really due to changes in ACLS and BCLS. So the other thing is that current ACLS teaching does not take into account available technology as well as differing institutional needs. So I think the way forward is to implement a more adaptive training program, which incorporates new technology. And this has been done in the United States, initially pioneered by Dr. Dan Davis from California, from UCSD. He started out the ART program, which stands again for Advanced Resuscitation Techniques. Now, this was way back in 2007. And from here, you can see this is an example of one of the many hospitals in the United States that have implemented ART. And you'll see that in 2007, when ART was implemented, the arrest incidence dropped and the survival increased. So this is what we want to see in our hospital. And ART isn't just high performance CPR, it's more of a bundled kind of package which includes rapid response. So that's where we work on our outreach and our red zone activation. It involves high performance CPR, but it also involves good post-resuscitation care. That's something that we will be looking into as well. Things like TTM, neuroprognostication, good organ support, early revascularization where appropriate. So again, to reiterate, ART involves integrating technology, principles of resuscitation science, and education to improve outcomes. It's a targeted resuscitation, and it's tailored to the expertise of the level of the provider. It's not a one-size-fits-all kind of program. It includes early detection of deteriorating patients and arrest prevention. There is a pre-hospital component to it, as well as a post-resuscitation care bundle. All right. So we are all familiar with this, where this diagram essentially shows on the y-axis the vascular pressure, the coronary perfusion pressure. This is in an animal model, and 50 is generally thought to be the threshold whereby the chances of ROSC increase significantly. So these spikes here, as you can see, are CPR being performed, and the aortic pressure rises and hits that threshold of 50 towards the end of the CPR cycle. And the moment you stop CPR, it drops significantly. And then it climbs up again. And at the end of the CPR cycle, it drops. So you see that here, all right? So safe to say, it's clear that interruptions to CPR would result in a drop in the coronary perfusion pressure, in the aortic pressure. The other determinant of whether you reach that threshold of 50 is the quality of your CPR. So these are the two key aspects of CPR that we want to target to achieve that high quality CPR that we're talking about. So we have CPR that's done by human beings, as well as we have mechanical devices that do CPR. Now, with mechanical devices, you can either get consistently good CPR or consistently poor CPR. And without any feedback, without any device that's giving you information on rate, depth, and recoil, you will not know whether you're doing good CPR or whether the mechanical device is doing good CPR or bad CPR. Thankfully, we've got new technology, and this new technology is able to give us feedback on the quality of our CPR as we are doing it. So it's real-time feedback on depth, rate, recoil, and gives you an overall idea of the performance of your CPR. And through this, we can achieve optimal CPR, include this in training, and optimize our CPR every time. So we know that perfect compressions include compressions with adequate depth, rate, and recoil, as well as compressions that are uninterrupted. So we don't want to interrupt compressions, and we want them to be good compressions. And we can use end-tidal CO2 as a surrogate for perfusion. And as we see the end-tidal CO2 rise to about 20 or so, we know that we are delivering high quality CPR. That together with the real-time feedback that we are getting, as well as filtered ECG, which I'll talk about shortly. All right, so what are oil pump compressions? So oil pump compressions, essentially, there's a video here which I will include in the link. So oil pump compressions essentially are compressions, a technique of chest compressions, which we'll cover in the practical session, where recoil is adequate. Because many people do CPR and the compression, the downstroke is good, but the recoil is often poor. And oil pump compressions basically uses the fingers as levers to enable adequate recoil and to optimize the recoil of each compression. And that's something we'll cover in the practical session.
I usually put that part down first and then put the fingers down like this so they keep my place, maintain contact, and then I'm coming up and down, allowing the chest to completely recoil each time.
So not sure whether that will come out in the final video, but that's an example of oil pump compressions. Right, so we talked about real-time feedback. Yeah, so where we get rate, depth, and compression. Okay, so that enables us to optimize the CPR. Now, the second issue is interruptions. All right, when do we interrupt? We interrupt, number one, interrupt CPR for ventilations. So before you have a definitive airway, you would be doing, according to BCLS and ACLS guidelines, 30:2, compression is to ventilation ratio. So in that two ventilations, in that two breaths, rescue breaths that you give, that will take about 2 to 3 seconds or so. And that's a significant interruption of the CPR. The second time that you interrupt CPR would be to check rhythm, to do a pulse check. And traditionally, according to ACLS guidelines, that's done every 2 minutes. And it should be no longer than 10 seconds. Now, 10 seconds is a long time. 10 seconds will allow your aortic pressure to drop to near zero. So 10 seconds is too long to stop CPR for. Now, the third time that you stop CPR would be to defibrillate. Again, the pre-shock and the post-shock pause can be up to 10 seconds. This is unacceptable. It's too long to stop CPR. So I'm going to talk about how to minimize these interruptions. Firstly, ventilation. Now, patients can actually be ventilated synchronously on the upstroke of every 10th compression for a very brief, very brief period of time. A quick ventilation can be given in less than a second. This has been demonstrated in animal studies. Of course, there are no large-scale human studies at this point in time, but it is feasible and it is something that can be achieved. Animal studies have shown that in that short period of time, you can give a quick breath and achieve adequate tidal volume with minimal gastric insufflation because of the recoil and the negative intrathoracic pressure created during the upstroke. So this breath is timed to the upstroke every 10th compression. So to achieve this, of course, a certain amount of coordination is required. So you will need 2 people at the airway, one person using a 2 thumbs up approach to press to hold the mask down, and a second person with the bag timing the compression so that on the upstroke of every 10th compression, a quick breath is given. So in that fashion, we can achieve synchronous ventilation and avoid interruptions. Of course, once the patient is intubated, there isn't the problem of stopping ventilations anymore. So as you see here, a breath is delivered on the upstroke of every 10th ventilation. All right, so the second time you actually stop CPR is actually to check the rhythm, okay? Now, with new technology, we've got filtered ECG. So what does filtered ECG mean? That means on the display monitor, you will see the underlying rhythm without the artifact of the chest compressions. So you will be able to tell what the underlying rhythm is. So in that way, you don't have to stop chest compressions to analyze the rhythm, because you will be able to see the underlying rhythm as the chest compressions are being done. All right. Secondly, when it comes to ventilation, we've talked about that. We can do synchronous upstroke ventilation, okay? Thirdly, when it comes to defibrillation, all right, we are able to defibrillate and minimize the pre-shock and the post-shock pause, okay? So I'll talk about defibrillation in the coming slides, but just to reiterate the point on rhythm check. So you only stop to check a rhythm when you have, number one, a perfusible rhythm seen on the filtered ECG, and number two, a rise in end-tidal CO2. So a rise in end-tidal CO2 signifies a return of spontaneous circulation. And when you have that rise of 5 to 10 millimeters from your baseline, then you know that together with a perfusible rhythm indicates a return of spontaneous circulation. And that would prompt you to stop CPR and to check, to do a pulse check. There should not be a pulse check under any other circumstance unless you recognize that there is a perfusible rhythm with a rise in end-tidal CO2. So in that way, you can do uninterrupted CPR. With the feedback, you can do good quality CPR. And now we'll talk a little bit about fatigue, all right? So it's recommended that every 2 minutes, somebody rotates to do the CPR to prevent fatigue. Now, with your real-time feedback that you will see on the CPR dashboard, you will be able to detect fatigue by the fact that the depth of the compressions will drop, the rate of the compressions may drop as well. Essentially, the quality of the CPR drops. And when you notice that someone might be getting tired, the quality of CPR drops, it's time to switch. We talked a bit about this earlier, the use of end-tidal CO2 intra-arrest. All right, so end-tidal CO2 is very useful, and what the information that you can get would be basically to prognosticate. Number one, if your end-tidal CO2 is persistently low, less than 12, that usually portends a poor prognosis. It can predict the success at defibrillation in a sense. Some studies have showed that an end-tidal CO2 of more than 25 are associated with a significantly better shock success. And most importantly, it can detect ROSC by a sharp and sustained rise in end-tidal CO2. This is an example of the CPR dashboard seen on the Zoll defibrillator. So right on the top here, this is your feedback that you get as you're doing CPR. You will see that the depth is displayed, the rate is displayed. This bar here indicates the release, and when the bar is full, there is adequate release. And this diamond here indicates the performance index. So it's a sum of the release rate, is a composite rather of the release, the rate, and the depth, right? So when you have adequate release, adequate rate, and adequate depth, you will get a full filled in diamond. As your indices of CPR do not meet their targets, this diamond would start to hollow out, all right? So while somebody is doing CPR, that person can actually get both a visual feedback as well as audio feedback, where the machine will prompt you to push harder or push faster or to release more. At the same time, if you have the manpower to spare, you can have a CPR coach, so that someone standing behind the person doing CPR and telling them that they're pushing too hard or too soft, too fast or too slow. And this will be done as they're doing CPR. In this middle row here, you will see the word FIL, that stands for filtered. And what you're looking at would be the filtered ECG. So this is the ECG reflecting the underlying rhythm, taking away the artifact that you see when you're doing chest compressions. And on the left-hand side of the screen, you would see the respiratory rate as well as the end tidal CO2. So as mentioned earlier, if you see a perfusible rhythm together with a rise in end tidal CO2, that will prompt you to stop CPR and do a rhythm check. Now, defibrillations. Defibrillations often result in a significant pause in CPR. So what we hope to do is minimize this pre and post shock pause, and this can be done very effectively by pre-charging the defibrillator, keeping the hands on the chest, making sure everyone else is clear first, and then a brief hover over the chest for a shock, followed by an immediate return to CPR. So this pre and post shock pause can be minimized to 1 second or even less. Now, ACLS has of course done away with stack shocks. However, as I mentioned earlier, we need to think about the individual circumstance in which the patient arrested. For example, if a patient has pads on and arrests in front of us, we would often see a very coarse VF or VT. Now, they would still be within the electrical phase whereby defibrillation would prove to be effective. In such a circumstance, it may be useful to try more than one shock. Stack shocks may have a role in such patients where you do 2 or 3 consecutive shocks before you start CPR. However, the converse is also true. For example, if you've got a patient on the streets who arrests, and by the time the SCDF arrives or the AED is brought to the patient may have degenerated into PEA or very fine VF. Now, in such a circumstance, an immediate shock may actually prove to be detrimental and may reduce the chance of ROSC. In such a circumstance, it may be prudent to do CPR for 2 minutes, as well as give a dose of adrenaline to prime the heart, to increase the CPP, coronary perfusion pressure, to increase the ATP stores in the heart before giving the shock. All right, so again, I wanted to talk a little bit about the use of adrenaline. So as we know, ACLS states adrenaline should be given every 3 to 5 minutes. We often give it every 4 minutes. There has been recent evidence that adrenaline has been associated with poorer neurological recovery. So adrenaline should be used judiciously, and there may be some circumstances where you want to delay the dose of adrenaline to the 5-minute mark. That still falls within the ACLS guidelines, all right? Instead of giving it at 3 minutes, you give it at 5 minutes. However, there may be some circumstances where you would want to prime the heart with adrenaline. For example, a patient that has come into the ED off the streets, has not had bystander CPR, is in fine VF, which alternates with PEA. In such a circumstance, you want to do good quality CPR and prime the heart with a dose of adrenaline prior to shock. So this is the ART arrest algorithm. It's a simplified algorithm which basically guides the user as to when to defibrillate, when to do a rhythm check, and when to do CPR. So it's fairly simple. It's much simpler than the ACLS algorithm. So as you can see, obviously you assess the patient, and you assess the patient's not breathing and has no pulse. So the patient is dead. Now, if the patient has pads on him or her, and for example, a patient in the ICU arrests and has pads on, or in the cath lab, or just out from the cath lab, you may consider early stacked shocks. If not, start CPR. And you remain on CPR island. Now, what do you do on CPR island? On CPR island, you want to make sure that you're doing good compressions. So that's where your high quality CPR comes in with real-time feedback. You want to give appropriate drugs. You want to look for your reversible causes. And at the same time, you want to find a reason to stop compressions. When would you stop compressions? You stop compressions briefly to defibrillate, and you stop compressions to check if the patient has come back to life. And that only occurs when you see a perfusible rhythm with a rise in end-tidal CO2. And then you move on to post-arrest care. So this is a simple conceptual model on how to approach a patient that has gone into cardiac arrest. At the end of the code, a report card can be printed out. So this is an example of an event summary. So this enables a quantitative debrief at the end of each resus. It also enables data to be gathered and for targeted training to occur in areas where we find that certain qualities are lacking. So for example, in this report card, you can see that the depth is an issue, right? So the blue bars indicate adequate depth and the gray bars indicate inadequate depth. All right. And if you look at the pie chart here, you will see that the compression fraction is only 60%. Tells you the longest pauses, the pre-shock pause and the post-shock pause, the CPR pauses, your depth variability and your rate variability. So here you can see that only 60% of the time was the resuscitationist or the operator on the chest. Almost 40% of the time was spent off the chest, so that's quite poor. So in this way, you can do a debrief at the end of each session to say, look, what went well, what didn't go so well, the depth wasn't the best, that's something that we might need to work on. We're taking too long to defibrillate, maybe we should do a sim session to simulate a quick defibrillation with a hover and a short pre-shock and post-shock pause, that sort of thing. So targeted training can occur with these debrief sessions. All right, so this is just an example of another medical center in the United States where survival improved after implementing the ART program. Again, this is Mayo Clinic. So Mayo Clinic teaches the ART program to all their staff, and they have also shown improved outcomes. Yeah. So when we talk about the elements of a successful resuscitation program, what we want to do is we want to customize the approach to our institution, to Teng Fong, right? We'll work with whatever resources are available, and we will try to do focused, targeted training. We don't plan to do away with BCLS or ACLS. That will still be taught in the conventional fashion. What we hope to do is to improve the quality of the resuscitation, to make people understand that you can do a more tailored and individualized approach to resuscitation, and to use available technology to improve our outcomes. We want to have a training program that is more adaptive to the need of the providers. And we want people to take ownership and accountability for their performance during that code and when they are delivering CPR. So I'm going to include this link here. This is an example of how a code should be run and how it is run with the incorporation of high performance CPR and advanced resuscitation techniques. With that, I thank you, and I would be happy to answer any questions, either personally or via email. And I look forward to seeing you at the practical sessions.